Yeah, we just started out by talking about the potential that evidence-based care coordination has in delivering savings in the Medicare program. We think the potential of a couple $100 billion. But as we've been talking about, none of this works absent having health information technology. So in that, with that respect, Senator Whitehouse has earned a well-deserved reputation for being a tireless and vocal advocate in Congress for using information technology as a tool to improve health outcomes, stop the spread of chronic disease, and save billions in the Medicare and Medicaid program by keeping people healthier. I think he very importantly highlighted this in two important Health Committee hearings, one last week in which he chaired on delivery system reform, one of my particular favorites. Enjoyed that. And another last month on the state of chronic disease prevention, both topics right in the core of what we do here at PFCD. In the Senate and before that as Rhode Island's Attorney General and U.S. Attorney, Senator Whitehouse is focused on the well-being of families, children, and seniors, protecting consumers, helping small businesses grow and create jobs, and assisting the unemployed and all those hit by the recession, the changing economy, and hard times. He's a graduate of Yale University, and University of Virginia School of Law. He was elected to the Senate in 2006. And had the pleasure of meeting him that first year when he arrived here. In addition to his role in the Health Committee, he also serves on the Budget Committee, Environment and Public Works, the Judiciary Committee, and the Special Committee on Aging. He lives in Newport with his wife Sandra, a marine biologist, an environmental advocate, and their two children. So it's a real honor and pleasure for us to have Senator Whitehouse to spend a couple of minutes with us today. So, Senator.
Thank you, Ken. Thank you, Ken, and it's great to be here with all of you. Since I signed for the room for you, I just have to ask that you not trash the place. I don't know if it's that kind of a crowd or not, Ken, but
I think it's well behaved.
Well behaved. Okay, good. I really want to thank you all for what you are doing. Admiral Mullen is the head of the Joint Chiefs of Staff. He has said that our debt is the #1 national security issue that the United States of America face. So there's data point 1. Data point 2 is that President Obama and Congressman Ryan agree that if you want to talk about our debt and deficit, it's a health care problem. And data point 3 is that we are wildly out of virtually every norm with respect to health care cost versus outcomes. The President's Council on Economic Advisors says we're over by $700 billion a year where we should be. The Institutes of Medicine just came out at $770 billion, rough numbers. New England Healthcare Institute is at $850 billion, and the Lewin Group, which is pretty widely respected, and buttressed by George Bush's Treasury Secretary O'Neill, who knows a certain amount of this from his days running the Pittsburgh Healthcare Reform Partnership, is at $1 trillion a year. So here you have this enormous target for savings that connects by two very easy logical leaps to make to the #1 national security issue that our country faces. And we're not doing much about it that's very useful here in Washington. For those of you who are watching the health care reform bill, actually probably somewhere between 30 and 40% of that bill was delivery system reform, and the Innovation Center, and the Payment Advisory Board, and the various pilots that are all in there, I think are adding up to some very good stuff. But if you watch that bill pass, you'd never know that any of that was in it because there was no conflict, so nobody has any idea that it's there. More people think death panels were in the bill, which weren't, than believe that serious delivery system reform was in the bill, which was. And part of the reason for that is that in Washington, two things are going on. There is a real problem in healthcare that there are real ways that we can solve, and there is a cartoon about healthcare that most of the attention is directed to, and the cartoon bears virtually no relationship to the actuality. The cartoon serves political ends. It creates a narrative that certain people want to propagate, but it just plain isn't reality. It's no more reality than Porky Pig is reality. But it's out there. And it's very hard to fight around because people who want to propagate that narrative and propagate that cartoon can hardly stand to listen to a discussion about the reality of it, because every moment that you're having a discussion about the reality of it, you're missing an opportunity to propagate the narrative and to continue to inflate the cartoon. So it creates a bizarre situation. However, I think the administration is working very hard to try to get this done. We've done everything that we can at this point with legislation, I believe. I agree with the economist who took a look at this and said, on delivery system reform, everything you could want is in there. In fact, everything you could think of is in there. And now it's stopped being a legislative task, and now it's really an administrative task to plow through that and turn the instructions of the law and the authorities of the law into operating regulations in the Code of Federal Regulation, into actual programs. And I have been asked by Chairman Harkin on the Help Committee to do a review of the administration's performance in achieving those goals and seeing whether there's, thematic consistency, or whether it's Winston Churchill is alleged to have said, picking at a dessert that didn't impress him, this pudding has no theme. We want to make sure that they see a theme and that they're following it. And so we'll be using our oversight authority to try to make sure that that takes place. But underneath all of that, the sort of government side of it, is the fundamental fact that there is a reason that we have the appalling costs that we do compared to the quality of care that we receive, and we are in a position to do something about it. It has a lot to do with chronic care and the kind of conditions that make 5% of Medicare recipients burn up more than 50% of Medicare costs. It's that population that is probably going to be best served by these delivery system reforms in terms of increased quality of care, increased efficiency of care, increased better experience of care, and improved outcomes, and at the same time create for the system dramatically lowered costs. So the focus on chronic care patients is exactly the place where you get the best bang for the buck, I believe, and so I'm really delighted that you're working in that space. And I also believe that you can't get that done without having the infrastructure in place of information technology to support it. I talk about the sort of 5 tools that we have to go after this problem. One is prevention and primary care. The other is quality improvement, no more hospital-acquired infections, no more medical errors, that sort of stuff. Dial that down, which you can do with proper incentives, which takes you to the third, which is payment reform, so that the incentives line up right and you're paying for value and outcomes, not volume and procedures. And then finally is the sort of administrative overhead of the system, where my guess is that 20 cents of every American healthcare dollar goes to spend in the battle between providers and insurers over getting paid. Before you even get into healthcare dollars, you have to burn 20 cents on not only the insurer side of the equation. They're actually pretty efficient about trying to figure out how not to pay providers and doctors and how to delay paying providers and doctors. But now the doctors and the providers have to do their side. They've got to reciprocate. It's kind of an arms race. And they're less efficient at it. They're not as good at it. They're not centralized. When they try to get together, they've got an antitrust problem, whereas a big insurance company has it under a single corporate shell, so it doesn't have that worry and it can plow ahead. So whatever the number is on the insurance company side, you know it's bigger, that the shadow is longer in the provider community, and you have to sum those two to get a real sense of what the unnecessary administrative cost is. And all of those areas are areas that will be served and indeed may only be maximized through a really solid health information infrastructure. And I would further argue that that's the kind of negative side of the equation. But that's sort of how you solve the problem that we have. It also opens 2 incredible doors to the future, I believe. One is that the time will come fairly soon when, just as you download an app onto your iPhone, there will be apps for your health care that are personal to your condition and your history and your situation, and that will support your doctor and the primary care nurse that is coordinating the care and yourself through all the decision points that any chronic condition of care requires, so that there's less slippage and there's more compliance and there's less confusion. And all of that is the perfect thing to automatize. And if we're actually keeping track of outcomes, you can actually find out which app works better for which kind of people, and so you can choose your best app, and suddenly you're in much more control of your own healthcare. That, I think, is an industry that's going to explode in the decades ahead, and we can own it, and we can export it, and it can be really an exciting new technology area. The other is once we get de-identified data in large aggregated amounts, and everybody gets comfortable that we can keep it individualized and keep people's privacy protected, now all the quants and the really smart genius people can go growling through all that stuff and figure out what the anomalies are, what the associations are, why are they there, what this isn't expected, and you learn from that, and it's a whole new field of learning and a whole new front, I should say, of medical analysis and endeavor. So this information technology piece is absolutely vital to all of that, and so that's the reason I'm so just relentlessly committed to this thing, because without it, we don't get there. With it, we do get there rapidly, better. I'll leave you with one point, which I think is the one failing that I see in I think there are two minor failings in the meaningful use program. The two minor failings are that it doesn't provide for anything to do with nursing homes, and it doesn't provide for anything to do with behavioral and mental health. And I think they need to carve out chunks of the meaningful use pool for meaningful use providers who are coordinating with behavioral health and who are coordinating with nursing homes, because you want them in the loop of the information infrastructure. We'll get there sooner or later, so I consider that to be relatively two minor improvements, but significant ones. The major improvement is that right now it is very hard to exchange health care information. It's easy to set up an EHR. It's easy to put the computers on the doctor's desks. It's easy to do a lot of this stuff. It's very hard to get all the machines at the primary care provider, at the specialist, at the lab, at the imaging place, at the hospital, all talking to each other and populating the necessary data the way they should. The one way that works very effectively, I think, is the accountable care organization structure, because it's a corporate command and control structure, and the person at the top can say, this is what we will do, and off you go. Rhode Island is not probably going to file an affordable care organization application. We're not going to have an ACO. That's going to be true of an enormous amount of the country. How do you build a health information exchange outside of the corporate boundaries of an affordable care organization? Nobody's figured that out. Nobody's figured out how you make it self-sustain. Nobody's figured out how you generate the revenues to manage it once you've built it. There were great funding vehicles that were in the bill that, frankly, I worked very hard to get in the bill, that have put a lot of money into the construction of early health information exchanges, and places like Rhode Island and Indianapolis are really trying to push very hard on this. But nobody's yet come up with a business model that allows it to persist. And I think we need to really push on that. I don't think we're going to solve this problem faster than we can solve the health information exchange problem. That's the lead dog problem, and you're not going to go faster than the lead dog, so you want to make sure that lead dog is going as fast as possible. And so I think that with all the money that we're spending on meaningful use and support for information infrastructure, we've got to put an extra focus on the information exchange problem and do everything we can to propagate that. There's a breakthrough point where it just kind of becomes, we've solved it now and everybody wants in, and it kind of goes viral, and you're no longer pushing the spaghetti up the hill, but it's rolling down the hill on its own, if that's not too awful a metaphor. But so that's where I think we are, and look forward to your continuing support. But truly, this is the most important domestic issue our country faces. It is being solved by you as you work day to day, and I want to take this occasion to thank you for that and to celebrate the accomplishments that you are achieving as you go forward. Thank you.